Okay, this afternoon I'm going to give a presentation on predicting the need for PEG tubes in head and neck radiotherapy patients, which is a project I've undertaken as part of my PhD at the Austin Hospital in conjunction with my co-authors here and also through Monash University. So radiotherapy is really critical in the management of head and neck malignancies. It really does encompass multiple tumour groups across many regions in the head and neck. And what this leads to is increased radiation-induced toxicities generated by a normal tissue complication due to inadvertent radiation dose to critical structures in this region. And this affects patients in both the acute and late settings. So we're getting radiation-induced toxicities during their treatment and also for many months and sometimes years beyond their treatment. So as many of us are aware, cancer survival has increased significantly over the last 20 to 30 years. And this is in particular in the head and neck patient group as well, where a large majority of our patients are living far greater, far longer, and living beyond their treatment that they're receiving for their cancer. So what that really leads us into is improving the quality of life beyond their treatment. Not only nowadays are they receiving their treatment, but there's this expectation that once they finish that their quality of life beyond that is optimised as best as it can. Dysphagia is one of these toxicities that can be really debilitating, not only during a course of radiotherapy, but also long beyond. But however, understanding dysphagia is really tricky. There's so many different variables which can contribute to dysphagia. That can be a lot to do with the radiation that they're receiving as a form of treatment to manage their cancer, but also due to various other ailments, pre-existing morbidities, the type of tumour, the stage of the tumour, the age of the patient. There's so many variables there which we need to consider. So it can be a really tricky process. So this particular component of my PhD wanted to look at being able to predict these patients who are going to experience dysphagia and try and predict these patients as early as possible within their treatment regime in order to maximise their supportive care interventions throughout the course of their treatment. So the first component of this project was to determine which clinical factors in a head and neck radiotherapy patient are predictive of not only using a PEG tube, but also the length of time they'll be using a PEG tube, and also for the intensity they'll be using their PEG tube also. So they're using it they're requiring it for more than 25% of their nutritional needs. And we were hoping this would translate to really early identification of patients who will require a PEG to enable us to initiate those supportive care interventions in terms of dietetics, speech pathology as early as possible. And also to identify patients who may have been given a PEG tube or maybe routinely given a PEG tube who maybe don't need one, so that we're eliminating the need for that intervention, which is obviously an invasive procedure and the associated risks that come with that. So we looked at a whole series of independent variables as potential predictors for PEG feeding. These are a lot of demographic characteristics, tumour characteristics, pre-existing comorbidities, to really see whether the presence of any of these prior to someone commencing their treatment were indicative of the need for PEG feeding throughout the course and beyond their treatment. So what we found in this study, after a multivariate analysis, what we found was large tumours, so those which were T3 or greater, who had level 2 nodal macroscopic disease, were those who really required a PEG for more than 25% of their nutritional requirement, but also for lengthy periods of time. So if we broke it down into each of these sections, if you look at the median duration of PEG feeding for a patient that, say, had a small tumour, but with level 2 nodal involvement, they required a PEG tube for 11 weeks. If they had a large tumour with no level 2 nodal involvement, they required a PEG tube for 15 weeks. And if they had both of these characteristics, that being a large tumour and level 2 nodes, they were going to feed for close to 6 months. So really significant data we were able to extract from this analysis, which is really exciting. So if we put that into relative terms, a patient with a small tumour with no nodal involvement will recover, so recovery being defined as a return to their normal eating habits or non-PEG dependence, they'll recover 9 times faster than a patient who had a large tumour and level 2 nodal involvement. So if we look at it in relative terms, it's a really significant discrepancy between these two groups, and was something we're really excited when we found these results to be able to help manage these patients as they move forward. So the initial study was looking at factors that we knew before a patient came to their radiotherapy appointment. This was presented in an MDM before even the decision to proceed with radiotherapy was even made. what we wanted to do in this predictive model was establish a model once they've actually had the radiotherapy specific delineation and dose planning done, the component, to see whether once we had that information in addition to the pre-treatment factors, whether that would change and whether that would potentially change whether a patient may or may not be recommended for a PEG intervention. So the aim was essentially the same, and what we would want to do is again identify those patients with the addition of this extra information to determine whether a PEG tube intervention was required, and also those at the highest risk, so that we could again initiate those supportive care interventions, and again identify patients who may not receive a PEG tube, which I should specify at the Austin Hospital, it's generally a prophylactic PEG centre where most patients will be given a PEG. So what we want to do is highlight those patients that maybe were given one, and as I said earlier, due to the risk associated with a PEG insertion, we want to eliminate those patients that maybe don't need one. So we take a look at the swallowing anatomy of the neck, and this is something we were able to achieve once we initiated the radiotherapy component. So we looked at a whole series of structures in the anterior neck, from the oral cavity, base of tongue, to the pharyngeal constrictor muscles, or the PCMs, down through the larynx, all the way down to the cervical esophagus. And each of these structures we were hoping would have a different role in the swallowing mechanism, and we were trying to isolate which ones, when affected with inadvertent radiation, were most susceptible to causing dysphagia. Routinely, we would just look at the larynx. Prior to this project, the larynx is a surrogate for the anterior neck as a predictor of dysphagia. But what we wanted to do was really have a better understanding of each individual component in that mechanism to see the role it played, and hopefully isolate the key structures in this process. So what we found in this analysis was that, again, which is really important, really exciting, that through the multivariate analysis, we also found that those with large tumours and those with level 2 nodes came out in the wash, which was really exciting. So what that showed us was that even if after the addition of the radiotherapy information, a person with a greater than T3 and greater tumour with level 2 nodal involvement, they're the ones still after this analysis were the ones who we need to highlight as at highest risk. We also incorporated some of the key structures involved in dysphagia, and those being the superior pharyngeal constrictor muscles, the base of tongue, and cervical esophagus. So really what that did, it really gave us an extension of the data we already knew. So the most exciting bit of that being is we were still able to rely on that T stage and level 2 nodal involvement as key predictors. And again, the most exciting bit of that being is that we know that as soon as a patient presents to us in an MDM setting, so we're able to initiate those pathways before they even step foot in the radiotherapy department, which is really exciting. So what next? So now we've got this data, we want to be able to validate this tool in a retrospective cohort. So patients that weren't used in the development of the initial model, we want to gather. So we're in the process of developing that data now, with the idea of running about 50 patients through the tool. Look at how they fed, so whether they used a PEG, for how long, for what intensity, and then comparing that with had we used the tool to predict their PEG feeding, how well they correlated, to see whether the tool is actually valid in the clinical setting. And following this, all going to plan and all those results being indicative of what we think they will be, there'll be the follow-up with the clinical implementation of this PEG predictive tool to really help guide nutritional support decision making, and in particular as early as possible in the patient treatment pathway. So the idea being that it would hopefully be implemented into a multidisciplinary setting, so that we could use this on patients again at the start of their treatment journey. So thus far we've had some work accepted for a presentation in London in June, looking at, it's called the International Conference on Computers in Radiotherapy. It looks at innovative ways of presenting data and developing predictive tools to help drive practice. So that's really exciting. We've completed a manuscript draft for the for the study 1, which I discussed just before, looking at those predictors prior to radiotherapy. So that manuscript's in preparation, hopefully to be submitted very shortly, which is exciting, and that will again be followed up with the addition, another paper with the addition of the radiotherapy specific characteristics also. So NEMICS has been the support I received from this grant was really useful in providing that statistics support, which is far beyond my statistical knowledge. So we're fortunate enough where we've had some support from we've had association with a group, or a lady who's got a strong radiotherapy background in doing statistical analysis. And this particular project involved a lot of regression, a whole series of tests which are far beyond my scope. So we were really fortunate that we were able to through the grant, get the support for this analysis and really undertake a really robust analysis of all this data that we had. We had a lot of data, but obviously once you've got a lot of data, the most important thing is to make sure it's analysed properly, and especially as we're looking to implement this into our clinical practice, we want to make sure it's done properly. So the grant really enabled us to do this and get the proper statistical support. So as I touched on briefly, having statistical support such as this really ensured that the data was clean. Our statistician was meticulous in ensuring that every bit of data she had made sense, and it was in line with what we set out, the aims we set out in the project from the beginning. Made sure the data was robust, and as I said, it's really imperative when we're using this data to potentially implement change in our practice. It's imperative that this actually data we're developing, or the data we're using to potentially change our practice is actually clean and worthwhile. Enable us to really develop some really appropriate and correct conclusions, again, so that we were confident that the tool we'll be using in clinical practice is as accurate as possible, and allows us to really give some reliable recommendations as we look to drive and change the way patients are managed with data more so than experiential data, which is probably more commonly used these days. We wanted to have a real scientific base to our decision making. So the foreseeable benefits, I could really see this tool being really useful in a multidisciplinary setting where patients are presented, they first present to a department. What do we do? Do we give them a PEG? Do we not give them a PEG? The opportunity to use this tool in that setting to plug in those key parameters which we found along the way. And this may change as we develop the tool more and more, but then that can be used to drive the decision making. So patient X presents at the meeting, they've got a large tumour, they've got level 2 nodal involvement, they're going to feed for 24 weeks, we give them a PEG. It might not be that simple, there's going to be those who fall in that intermediate risk group, but I think this can really help drive that decision making process, again with science more so than experience, which I think is really crucial. And I think probably the most important benefit is that the transparency it also creates for the patients. They're coming to a department, they're being told they need to have a PEG tube, and patients these days, they want more information. So I think the ability to be able to share that information and make that decision making far more transparent, make sure that informed consent is exactly that, it's informed consent. I think that's really important. I think a tool like this will enable that to occur, which I think is probably the key and the most exciting aspect of this tool. So thank you.